I think yesterday or day before in the
Raisa.
I think yes.
Yes, sir.
Yes.
Good evening, sir. I'm the same Rachna Gupta. Thank you so much for remembering.
Because the DP looks little different from the.
It is 8 o'clock. Good evening, friends. Thank you for joining for our PG clinics. Today we have two students presenting on a mass abdomen from Dr. Hitesh from Rewa, the Shamshar Medical College from Madhya Pradesh. And the other candidate is kindly contributed by Professor Shamita Chatterjee ma'am from IPGMR Kolkata, Dr. Komal Sharma. So we have a very eminent invited faculty for the day. We have Professor R.K. Jaina from SMS Jaipur, Professor Supriya Naik from CMC Vellore, and we have Dr. Rachna Gupta herself from Rewa. And we have our esteemed panel of faculty, Dr. Shanai sir, Dr. Karnakaran sir, Rajiv Sahai sir, and others are joining. One birthday baby, I'm not sure whether she's joining or not. I hope.
Where is our Dr. Srinivasan? Yes.
I was just wanting to wish him once he joins. Let him come, sir. He said to join. So the mass abdomen candidate, Hitesh, you will be presenting first. Then we'll go for the other candidate. All right. So the invited faculty will take priority in asking questions. Let the other faculty also will be joining us in asking questions. Dr. Hitesh, can you please introduce yourself, your unit chief, your HOD, and start your PowerPoint?
Yes. I'm Dr. Hitesh Dikshit from Shamsa Medical College, Rewa, associated with the Sanjay Gandhi Memorial Hospital. I'm presenting my seminar on lump abdomen under the guidance of respected Dr. Rachna Gupta ma'am.
Krishna, Hitesh, you please wait for a minute. I think a lot of disturbance are there. 1 second.
Have you started the PowerPoint presentation, Dr. Krishna?
Hitesh, you please, faculty who are senior faculty, you please unmute yourself and speak. I have muted everyone as we had some disturbance. Faculty, please unmute yourself, those who are asking questions. Professor Garg sir, thank you for joining when you are traveling. Professor Garg sir from Rotak is joined also. Thank you. Welcome, sir. Hitesh, are you with us?
Dr. Krishna, you are muted.
Hitesh, please unmute.
Hitesh, you have any challenge, ma?
No, sir.
Okay, make it full screen and start your presentation.
Good evening, respected faculty. Myself, Dr. Hitesh Dikshit, RSO 3rd year, Shamsa Medical College, associated with the Sanjay Gandhi Memorial Hospital, Rewa, Madhya Pradesh, Department of General Surgery. I'm presenting my seminar over the abdominal lump. Here is the case of abdominal lump. A 22-year-old lady presented with the swelling in the left side of the upper abdomen for the last 2 years, which has been gradually increasing from last 2 years. There is no history of rapid increase in swelling. Patient is complaining of occasional dull-aching pain over the left side of the upper abdomen, fullness of the abdomen, decrease in appetite, regurgitation, no history of fever and symptomatic symptoms, no history of major ailment in the past. Moving to the next slide. Here I am showing the lump in a left hypochondrium. You can see the lump. This is the lateral view of the patient, where we can easily identify the lump, which was predominantly present in the left hypogastrium, which conquer the epigastric region and right hypochondrium and supraumbilical region. Chief complaints of the patient are swelling in the left side of the abdomen since 2 years, occasionally dull-aching pain in left upper abdomen since 1 year, regurgitation since 6 months, fullness of abdomen since 6 months, and decrease in appetite since 6 months. The history of the presenting illness of the patient, as narrated by patient herself, she was apparently all right 2 years ago. Then she noticed a swelling over the left side of the abdomen. Swelling was small, not associated with any nausea, vomiting, and fever. Then the swelling size increased with the passing time, and occasionally left side abdominal pain. Pain presented along with it. The pain was dilating and localized, not migrating, not associated with the fever, nausea, vomiting, then developed the regurgitation after eating food and decreased appetite, and felt fullness of the abdomen. Past history of the patient is no relevant drug history present, no relevant history, no relevant disease history present, no history of trauma, comorbidities, no hypertension, no diabetes, no tuberculosis. Patient is seronegative. Here HIV, HBsAg, and HCV kit are negative. No history of jaundice, no history of hematemesis, no history of bleeding PR. She is a newly married female, and there is no history of conceiving and abortion. No history of addiction, regular menstrual cycle present. Last LMP is 10th of August 2022. Normal bowel and bladder habits. She is having 5 members in her family, parents, and she is having 2 siblings, 1 elder sister and 1 elder brother. Don't have same signs and symptoms. There is no history of any abdominal tumor, breast cancer, and hereditary cystic diseases. So I'm going to the general examination.
Dikshit.
Sir.
Right. So by history, you just got a lump and nothing, no other significant history other than.
Yes.
So a lump in left upper quadrant.
Yes, sir.
So what do you think is you can make out from this?
Sir, as I saw this 9 quadrant of the abdomen, here we can see the left hypochondrial region. The structures present in the left hypochondrial region is liver tip, stomach, pancreas.
No, that's fine. We know what are the structures there. You tell me what could be the diagnosis that she's for 2 years she's been having this problem, and then suddenly she complains of what is regurgitation? What do you mean by regurgitation? Is it vomiting, or what is the difference between vomiting and regurgitation?
Sir, vomitous content of food bolus or food or content present in the stomach, which is due to the reverse peristalsis. Where the regurgitation is the acid displays over the esophagus, which is called the regurgitation.
No, we can regurgitate food also. It's not just acid.
Yes, sir.
Regurgitation is a passive procedure, right? While vomiting is an active, there's contraction of the muscles and all for vomiting. So she's having regurgitation. How did you ask for history for regurgitation?
Sir, as patient narrated, when she having food, then while she was in supine position, the content of stomach came out into her mouth.
So food particles were there, or was it just gastric secretions?
Yes.
No, she was having food particles.
Yes, sir. She is having food particles.
Okay. So in which condition will you get this kind of regurgitation?
कौन सा वाला दर्द हो रहा है तुम्हारा? 2 प्रकार के हैं?
Sir, when the esophageal sphincter pressure, when esophageal sphincter pressure is low, then the abdominal content passively regurgitate into the mouth. Then in this condition, the regurgitation occurs, or abdominal pressure increases. If abdominal pressure is increases, then regurgitation also occurs.
Any esophageal condition?
Sir, ecclesia cardia.
So the food which was regurgitated, was it old? Was it recently eaten food, or was it old?
Sir, recently eaten food.
Right. And how can you distinguish whether this regurgitation is from the esophagus or from the stomach?
Sir, if food the food travels from the esophagus to the stomach, it is a spontaneously traveling while we are deglute the bolus. Although the food stay in stomach up to 2.5 hours. So
no, I'll give you a hint. Stomach contents are acidic, while esophageal contents are basic. So can you give me a reason how you can distinguish between stomach and esophageal regurgitation?
If stomach regurgitation occurs, then patient is complaining of chest burn.
More important that when they vomit or they regurgitate the food on the floor, there'll be a mark. There'll be a mark of acid. Okay, the acid will leave a mark, right?
Yes, sir.
Okay. So what do you think? Right, sir.
Sorry, sir. Please go on. Is Dr. Nayak here?
Sir.
Can you just enumerate the chief complaints?
Sure, sir. The chief complaints are swelling in the left side of the abdomen since 2 years, occasional dull-aching pain in a left upper abdomen since 1 year, regurgitate of food since 6 months, fullness of abdomen since 6 months, and decrease in appetite since 6 months.
Usually the chief complaints are in chronology, no? Either ascending order or descending order. So I think, so 2 years, 1 year, and then 6 months.
Yes, sir.
So what do you think has happened to the initial swelling?
Sir, initial swelling is asymptomatic. So, and the swelling size is less. So patient is not facing any problem. Patient was not facing any problem with the swelling, but over the time the swelling was grown. Then the pressure effect can be applied, might be applied by the swelling.
Can you tell me, based on this history and the chronology, will you be able to target one organ? Which organ is swollen?
Excuse me, sir.
Which organ is affected or swollen bigger?
Sir, it might be spleen.
Okay, spleen. Now, suddenly after 1 year, it has started becoming painful. Initially, it is not painful.
No, sir. Initially, it's not a painful, but after 1 year, when the swelling was grown, then she complained occasionally dull-aching pain.
Yeah. So, why do you think what is the cause of this dull-aching pain?
Excuse me, sir. You are not audible, sir.
What is the cause of dull-aching pain? It was pain-free. Now it has become painful.
Sir, it might be due to the stretching or compression of the adjacent organs.
Okay. What happens when a solid organs increases
The solid organs present in the left. One reason is a liver tip, stomach, right, left adrenal gland, and splenic flexure of colon, transverse colon, are affecting due to the pressure effect.
So I think.
Dixit, will you like to mention about some pets in the family?
No, there is no history of close contact with pets.
Okay.
Krishna Dikshit,
Yes,
this apart from the stretching of the capsule, any other cause of the pain in a enlarging spleen, if you think so? Any other cause of pain? Yes, any infarction or any perisplenitis or anything?
Yes, sir. Yes, sir. Usually we can see in cocaine smokers, the cocaine is the main cause. Cocaine is a drug addiction where we can see the splenic infarction, even splenic rupture. But the pain, infarction, and rupture and hematoma is sudden and severe pain, which was referred to the left shoulder.
No, what? Yeah, okay. Maybe reference may be there. What I wanted was, since you mentioned splenomegaly, I only brought out the hematological problems related to spleen, resulting in an infarction, etc. Okay. So now, why didn't you consider a pancreas as a pathology? You only talked about spleen.
Yes, sir. Sir, if the pathology arises from the pancreas, then there may be the there will be the symptoms of fever.
No. 2 years duration. Why should pancreas? We are not talking about acute pancreatitis. Your patient's age is what?
Excuse me, sir.
Your patient's age.
My patient is 22-year-old.
22-year-old. Yes. She is a female now? Female.
Yes, she is female. Sir.
Correct. So now can you think of, you mentioned blunt abdominal trauma. Samara has solved it. But 2 years less. Any tumors can occur? Relatively younger, but she's quite young. Hello? Can somebody mute this Nord CE5G, please? Samar, I saw Dikshit mentioned blunt abdominal trauma. More than that, do you consider any pancreatic tumor? Okay, come back to the straight, not to waste the time. What are the tumors you know? Don't tell me adenocarcinoma. Anything else?
Sir.
So whenever you have a pain.
So there are two type of the tumors, whether it is parietal tumors or whether it is organ related.
No, just hold on. Not parietal. I wanted pancreatic cystic tumors. Okay, please, if you are not done, please read about it. Painless, slow-growing cystadenomas can attain a large size. Okay, there is some separate entity. So whenever you have a large swelling growing in the abdomen, 2 years duration, you need to consider that also. You understand, no?
Yes, sir.
You need to consider. Hello?
Yes, sir. Thank you, sir.
So another 1 or 2 comments from my side. Just go to the next slide. Please, all the postgraduates who are listening, please note down always the slide numbers to be put so that we'll have some idea. You are written here, not fever, etc., etc. Next. Yeah, immediately you have gone to past history and then comorbidity, you have written so many other things.
Yes,
which
sir.
You should have brought it along with the negative history in the history of present illness. No history of hematemesis, all that should have come there. You understand what I'm telling?
Yes, sir. Yes, sir.
This will not become under comorbidity. You understand?
Yes, sir.
After mentioning the mass, whatever size you have mentioned, the large size, no fever, this should have come, especially if you keep spleen in mind. Young patient, 22-year-old, what splenomegaly you expect to attain this large size?
So there are lots of cause of the splenomegaly, which may be
There may be lots of causes. Just concentrate large spleen.
Sure, sir. Sir, it may be hereditary spherocytosis, idiopathic thrombocytic purpura, leukemia.
All these 3 will not attain the size of what you have mentioned, that crossing the midline, such a big spleen. In thrombocytopenic purpura, spleen will be very, very small enlargement. What I wanted was chronic myeloid leukemia, portal hypertension. You understand, no? What is left-sided? What she can get? What kind of a portal?
Malaria and Kalajar as well.
Yes, sir. Yes, sir. Definitely, yes. So rather than those things, okay? So yes, if you keep that in mind, you should have brought this hematomesis, jaundice should have come there, okay? So that's all from my side.
Krishna, can you tell what are the causes of big lump in the abdomen in a 22-year female patient?
Sir, big lump in abdomen in 22 years old female patient, it can be the lump abdomen. It can be due to the liver, due to the pathology in liver or pathology in epigastric region and pathology.
No, give some diagnosis. Don't say liver and colon and spleen and don't say that. Give some diagnosis.
Yes, sir. Yes.
So they should give the commonest cause.
Epidermoid, epidermoid cystine in spleen, epidermoid cystine in spleen, hemangiomas in spleen, and lymphangioma in spleen, pseudopancreatic cyst.
Any physiological cause, Dr. Dishit? Any physiological cause? Of a large
big lump in a 22-year female patient. Yeah.
Who's recently married.
Can she be pregnant?
Can she
Okay,
be
that is
pregnant?
the commonest cause of big lump in the abdomen in a 22-year female patient, is it?
Yes.
And then you have to think about the ovary. In a female, 22 years female, you have to think about the ovary.
Yes.
Then you have to think about the kidney. And then you have to think about the spleen. And then you may think about the pancreas.
Yes.
Okay.
What sir is trying to say that
Because
you
your
should
mind,
think of
your
the
mind is
commonest
set up at the
causes.
spleen. That is why you are talking
Yes.
about with
Think of the commonest
spleen
causes.
pathology. That, yes.
We can add trichovajar as well.
Yes. What are the cardinal features of the portal hypertension, Krishna?
So there are there are three features in portal hyper. There are three cardinal features which present with the portal hypertension: esophageal varices, hypersplenomegaly,
So varices, splenomegaly, and
splenomegaly, varices, and ascites.
okay. Now give a differential diagnosis of the combination of the bleeding and the splenomegaly. Differential diagnosis of a combination of the bleeding and splenomegaly.
Sir, differential diagnosis, thrombocytic purpura. It is a thrombocytic purpura. It is a differential diagnosis of bleeding and splenomegaly. So from thrombocytic purpura can be present with the bleeding and the splenomegaly. Sir.
Commonest cause? Patient having the upper GI bleed and the splenomegaly. What is the commonest cause of having the upper GI bleed along with the splenomegaly?
So the commonest cause is the portal hypertension.
Yes, portal hypertension. Okay, enumerate some more causes. Big spleen and GI bleed.
Egyptian splenomegaly, Fenty syndrome, porphyria, idiopathic thrombocytic purpura, secondary purpuras, which occurs in due to the idiosyncrasy of the drugs, just alkylating agent, quinine, etc., and burns, leukemia, carcinomatosis of bone. These are the some other causes of bleeding with splenomegaly and the hereditary spherocytosis.
Krishna, you are very theoretical, Jaina. You have to come to the practical points, Jaina. Whatever you are telling about, all those things are very theoretical things. The common causes for the splenomegaly and the GI bleed is the portal hypertension, the tropical splenomegaly, the patient having the malaria, Kala Azar, or the leukemia.
Yes, sir.
Okay, these are the commonest causes of the patient having the splenomegaly along with the GI bleed. Okay, go ahead.
Can that be muted?
So there is turbulence. Sorry, sir.
Now, yeah, Dixit, go on with the examination, please.
Sir. Here, the general examination was done in daylight. Patient was in supine position. Examined was standing on the right side of the patient. The patient. Patient build is average, normal gait, hair color black, skin present in left eye since birth, no icterus, no pallor present, no facial swelling present, no neck swelling, bilateral chest expansion normal with respiration, left side abdominal swelling present, nail are normal and pink, bilateral, upper limb and lower limb normal, no bony deformity present, spine normal, no kyphosis, no lordosis, no scoliosis present. On inspection, patient is examined in the supine position. On examination, fullness in the upper part of the abdomen with fade line of demarcation, suggestive of some loculation collection in the supraumbilical region. normal abdominothoracic movement, no scar present, skin over swelling, no redness, no tension, no pigmentation, no engorged vessel present, no visible pulsation and peristalsis. Lump started from the left hypochondrium, crossing the midline and below reaching up to the umbilical region in supine position. Bilateral hernial sac normal. Size of lump is approximately 15 centimeter into 15 centimeter. Shape is globular. Upward and downward movement with respiration present. No impulse on cuffing. No visible axillary, inguinal and neck region lymphadenopathy. Neck veins are normal. On palpation, afebrile, non-tender, no guarding, perabdominal palpation. Perabdomen is afebrile, non-tender, no guarding, no rigidity present. Abdominal wall surface is smooth. Skin texture normal. Huge lump is palpable that move with the respiration. Lump is compressible and move with a change in position. No palpable pulsations. 20 to 20 centimeter large swelling present in the left hypochondrium, epigastric region and crossing midline up to the supraumbilical region. Margins are ill-defined. Spleen notch is palpable above the umbilical, suggestive of the splenomegaly. Consistency is cystic. Fluctuation is present. Up and down movement with the respiration present. Swelling was not ballotable. Swelling was reduced while performing the leg lifting Carnet test. Swelling was not pulsatile. Not possible to insinuate finger between the left costal margin and swelling. No visible and palpable bowel loops. On percussion, dull note present on percussion. No shifting dullness. Fluid thrill not elicited. Auscultation, no bruit. Normal vowel sounds audible. On parrectal examination, cavity is collapsed. Soft fecal matter present. No growth palpable and no active bleed present. Anterectal wall is normal. My provisional diagnosis is that this is the case of the cystic lesion of the spleen. And the differential diagnosis is epidermal cyst of spleen, splenic abscess, simple and congenital cyst of spleen, polycystic spleen, lymphangioma spleen, pseudocyst of spleen, traumatic cyst, mesenteric cyst, pseudocyst of pancreas, or mental cyst. These are my differential diagnosis. Here I'm showing some pictures, intra pictures. Here, first arrow is showing the large spleen, and
hang on.
Matthew, just stop there. Yeah, just stop there. Yeah, we do not require the operative pictures here, isn't it?
Yeah, just go back, please.
All right.
Dikshit, don't go like Shatabdi Express. Okay.
Yes.
One of the problems was the speed go fast. Can you go back to your provisional diagnosis? Let's start the discussion there. Yeah. So
why you say it is a cystic lesion of the spleen? The reason to say it is a cystic lesion?
Sir, the margins of the swelling is ill-defined and fluctuation is present. And on percussion, there is a dull note is present. So we can say the lesion might be cystic.
How did you say it is a fluctuation is present in this? How did you demonstrate that? To demonstrate a fluctuation in a spleen. How did you demonstrate that? It's an intra-abdominal lump, which is a mobile lump.
Yes, sir.
And you were able to demonstrate the fluctuation in that?
No, sir. Spleen is solid organ, so we cannot elicit the fluctuation.
If it was a hepatitis,
just say it's a splenomegaly. Why you are saying it's a cystic and give the differential diagnosis of splenomegaly?
Yes, sir.
Okay, the patient might be having just a simple atropical spleen may be there. Okay, that is the commonest cause of the splenomegaly. Why it is not a kidney lump?
Sir, when we insinuate the finger between the swelling and the costal margins, if the mass is arising from the kidney, then we can easily insinuate the finger between the costal margin and upper pole of the swelling. But
no, big mass arising from the upper pole of the kidney.
Yes, sir.
Big mass arising from the upper pole of the kidney. Can you insinuate the finger?
Sir, we can insinuate the finger between the costal margin and the upper border of the swelling. And the second, the differentiating point is where if the swelling arises from the kidney, when we percuss, then we can't. When we percuss, then we don't listen the tympanic note. But if the tumor is arising from the spleen, then we can hear the tympanic note over the loin area. And the second is
are you sure about what you are saying? That you get a tympanic note?
Yes, sir. If the swelling is arriving from the kidney, then we can't get the tympanic note. But if the swelling arises from the spleen, then we can get the tympanic note over the spleen.
What will be the cause of the tympanic node over a splenomegaly? So when you percuss the spleen, it is tympanic?
No, sir.
No, that is a splenic dullness, isn't it?
Yes,
that is a splenic dullness, not the tympanic. And you have not mentioned anything about the renal angle here. Have you mentioned about anything about the renal angle?
Sir, I'm explaining. When we percuss over the renal angle with the erector spiny muscle, if we get the tympanic node, then the swelling is arises from the spleen.
So you want to say the renal angle is the erector spiny?
No, sir. 12th rib.
The renal angle is on the erector spiny?
No, sir. No, sir.
No, it is the lateral border of that. It is forming the medial border of the renal angle. It is not over the erector spiny. So
Yes,
normally
sir.
the renal angle is dull or resonant on percussion? Normal.
Normal, sir. Sir,
normally it is resonant or
resonant, sir. Normally it is resonant, sir.
It is resonant because of what is the reason for the resonance in the renal angle?
Because of colon is passing in the area of renal angle.
Okay, and what is the band of colonic resonance?
The band of colonic. Excuse me, sir.
Yeah, band of colonic resonance.
Okay, the band of the tympanic node.
What do you understand? A band of colonic resonance.
Sir, if the band of colonic resonance is present, then tumor arises from the spleen. Oh, sorry, kidney. If the band of colonic resonance is absent, then the tumor is arises from the kidney.
So you don't know about that, is it? Band of colonic resonance, isn't it?
Sorry, sir.
Okay, band of colonic resonance is present in only about 10% of the patients who has got the renal tumor. It is a sign of the renal lump. Okay, but it is present in only about 10% cases. So if you demonstrate the band of colonic resonance, this is more likely to be a case of a renal lump.
Yes.
Okay.
Hridesh,
so these are the
you mentioned about
various differentiating features.
Compressibility of the swelling.
Excuse me, sir.
You mentioned about the compressible swelling. How the ischemic swelling can be compressible?
Sir,
what do you mean by compressible?
sorry, sir.
Secondly, the fluctuation part which you have mentioned, fluctuation cannot be elicited in cases of intra-abdominal lump. It's the hydrated thrill which can be elicited in cases of cystic tumors of the intra-abdominal site.
Yes, sir. Yes, sir.
So it is the hydrated thrill by which you can say it can be a cystic mass.
Yes.
So fluctuation cannot be elicited. Fluctuation is elicited only when you can hold the whole of the swelling with your hands. It cannot be elicited in intra-abdominal lump.
Yes.
Okay, you can proceed further.
So there are differential diagnosis: epidermoid cyst of spleen, splenic abscess.
No, just 1 minute, Krishna. Again, can you just go to your slides inspection somewhere there? Because a lot of mistakes you have done. I think we need to correct. This is the best time to correct. You see, skin over the swelling, no redness. Don't expect intra-abdominal mass like, subcutaneous swellings like, hemangioma, sarcoma. That is one of the reasons. That
Can you
is
just mute that?
that is the reason why you are confusing and telling compressible and all those things. Don't expect intra-abdominal swelling to become compressible, fluctuation, no skin redness. So no tension means what? See, this is not the schema, or this is not the way you present. You understand, no? You have to correct yourself. Okay.
Yes.
How did you? What is this? No tension means what do you have in mind? Inspection.
Sir, this is the typing error. Here I want to say that skin is normal. No tense skin is present, sir. Sorry,
No
sir.
tense. You mean to say stretching, stretching and shininess.
Yes,
Why
sir.
did you have pigmentation in mind? See, there are common things you mentioned, that all quadrants move correspondingly equal with the respiration, hernia orifice, umbilicus. All those comments are more important. And if the mass is visible, yes, that I have seen that. Don't say lump started. Okay, it may be little English error, but no problem. Lump is present in location, crossing the midline, all that is fine.
Sir, there is some turbulence, sir. You are not audible, sir. Sorry. Sir, kindly repeat, sir.
Hello, am I audible?
Yes, sir. Yes, sir.
So what I'm trying to tell is that those kind of things of you told me about errors, that's understandable. But what I'm trying to tell is normal method of presentation. Comments on the quadrants or regions, movement with respiration, then umbilicus, vague mass or whatever. If you are seeing the mass, details about the mass, etc. Okay,
Yes,
right?
Yes.
And next slide. You are written that hernial sac is normal. What is this? Hernial sac is normal means female patient. You should be extremely careful about examination of the genitalia in this patient. You can maximum see is no expansion, impulsion, cough. Okay.
Yes, sir.
You are written here no impulse on coughing, but there you are written that no hernial sac, something like that you are written. Suddenly you move to 1 minute. Show that next. Axillary, inguinal, neck veins. See, don't do such mistakes. You are only now inspection of the abdomen. Okay.
Yes.
Yes or no?
Yes, sir.
If the prominent veins are there in the neck, you should have mentioned in the general physical examination.
Yes, sir.
I agree. You can mention later because this is a screen, your diagnosis. At the end of the examination, you can tell, I examined thoroughly entire body for generalized lymphadenopathy. You can mention, no problem, but don't mix up here. That's what I want to say. Okay, right?
Yes, sir.
There are several few mistakes like this in your presentation. Please correct. Okay, please
And lymphadenopathy is not visible, isn't? You have written no visible axillary and inguinal and neck. Okay, they are palpated, so they are finding, not at this place. This is the abdominal examination. You are doing the abdominal examination, so all these things should not be coming in the hair.
Yes.
Okay, can you go to the next slide? At one place, you are saying afebrile and then non-tender. What is afebrile? Do you understand what is afebrile?
Yes, sir. So here I want to say that the local temperature is normal over the swelling.
Yeah. So you do not write the afebrile. Afebrile is the body temperature.
Yes, sir. Yes.
Okay.
Sorry, sir.
But here you have to tell about the local temperature which is there. Okay.
Yes, sir.
Abdominal wall surface is smooth. What does that mean?
So there is no granulation present over the swelling. The skin
You
is.
don't mention. Krishna, you have to go through the basic, books which are there, and you have to tell all those things according to that book. You have written so many things which are probably not written in any book.
Yes, Krishna, you need to take some help of somebody and improve your presentation.
Yes.
At one place
and huge lump is palpable. Now you are not talking subjective now. You are palpating this patient. So there's nothing like the huge lump. You have to tell the dimensions of that lump.
Sir,
Okay, so all these things, no, you cannot say at this time on the palpation. You have to exactly tell that what you are telling about 20 to 20 centimeter, but previously you are writing huge lump is there. Okay, and lump is compressible. What one of the examiners asks you, what is that compressible lump? What do you understand by that?
intra-abdominal lumps are cannot be.
No, they are not compressible.
Yes, sir.
You understand what is the difference between compressibility and the reducibility? What is the difference between compressibility and the reducibility?
Sir, I just forgot the difference between reducibility and compressibility. Sorry, sir.
Hernia is reducible, but a
Yes, sir.
hemangioma is compressible.
Compressible.
Okay, you can understand the difference now.
Yes.
So once
one
you
thing
release
you
the
have
pressure,
mentioned,
this comes back. Yeah.
margins are ill-defined. All margins are not ill-defined. You have mentioned splenic notch is palpable. If splenic notch is palpable, then how the margins will be ill-defined? You can mention about the some margins are cannot be reached. The upper margin or posterior margin cannot be reached, but the lower and middle margin you have mentioned about the splenic notch. So that definitely indicates the margins are well defined on medial side. The lateral margin or upper margin cannot be reached. So you have to mention that as well.
What is that moves with change in position you wanted to convey to us?
Sir, if there is a swelling, if that provisional diagnosis is omental cyst can be freely mobile and change its position with the change of the position of the patient.
That is a freely intra-abdominal mass we are talking about.
Yes, sir.
So how do you actually express this?
Sorry, sir.
We are palpating, no?
Yes,
So
sir.
while palpating, you are feeling the mass,
Yes,
and
sir.
you are moving from one quadrant to the other. So how do you describe this? It is not moves with change in position. It is freely mobile, or you can displace it, or moving in, transverse axis or horizontally. So it is the intra-abdominal mobility we are trying to describe on palpation.
Yes.
So moves with change position, probably it is not the correct terminology to describe this. So was this moving? You are able to move from left hypochondrium to right iliac fossa or left iliac fossa?
Sir, the swelling is mobile up and down, but it is little mobile in right and left.
Listen to me. It moves up and down with respiration. That is what you have told.
Yes, sir.
It's moving with respiration. But on palpation, when you say moving, how do you look for it?
This point is wrong, sir.
You should be able to catch hold of the mass and displace it in different direction.
Different direction.
Then only you say it is mobile.
Yes.
If you think it is a splenic lump, do you think it will be mobile?
No, sir.
100% no, or in some situations it can be.
So
Have you heard that term wandering spleen?
No, sir.
But very rare. But you are right. A splenic mass will not be mobile. It moves with respiration, that is the slight movement, but palpation wise you cannot demonstrate mobility in that. Whereas a omental cyst, yes. Ovarian cyst, yes. Okay. Can you show the next slide, please? So again, cystic thing I will discuss. Obviously, in this case, you can demonstrate fluctuation.
Yes, sir.
But the only way you can call that lump to be a cystic one is if you can demonstrate hydrated thrill. Swelling was not.
Okay, here you have written swelling was reduced while performing the Carnet test. Okay, when you use the word reduce means we are indirectly thinking of the hernia, that this is reducible swelling. This swelling is not reducible swelling, is it? The swelling decreases on. Okay, it is not reducible. So when you are doing the Carnet test, the swelling size decreases rather than saying that it is a reduced one. Okay. What type of pulsation you can elicit in a case of a lump in that area? And how do you demonstrate that?
Sir, can you please repeat the question?
How do you demonstrate the pulsations in the epigastric region or in that area which is in the upper abdomen? And what are the various types of pulsations?
Expansile pulsation and transmitted pulsation. We can demonstrate in the.
So how do you differentiate?
Sir.
Yes. How do you differentiate?
We can differentiate expansile pulsation and transmitted pulsation by patient by holding patient in a knee elbow position. When if the expansile pulsation is present in aneurysm, aortic aneurysm, where the in knee elbow position the pulsation is expansile. If the expansile nature of the pulsation is gone, then it is a transmitted pulsation. Then the swelling is not rising from the aorta or large blood vessel.
Yeah. So in place of patient making the patient knee elbow, even if you make the patient a lateral position, that is also good.
Yes.
Okay. So rather than, because knee elbow is a cumbersome position, so you can just make the patient lateral, and also then you can differentiate between the expansile pulsation and the transmitted pulsations. Okay.
Okay, Dr. Hades, I have got one more clarification. Such a large mass in the upper abdomen, do you think it will be palatable? Even if, let's say, this mass is arising from the kidney, yes. Do you think palatability is a possibility here?
Yes, sir. If large mass is arising from the kidney, then the palatability can be elicited.
So, what are the prerequisites to do this test?
Sir, patient should be in the supine position and the one hand over the abdominal wall, and the second and the another hand placed in a loin area.
One second, don't rush. Just now you have been told, talk slowly. You are repeating too many things. You are running like mad, and we are not able to catch you. And that is where your mistakes are coming from. So first thing is, let's speak slowly. So for a palatability, a mass which is pushing the abdominal wall, do you think you're able to perform?
So we can perform the palatability if the mass arising from the kidney.
Yeah, that we agreed. But a large renal mass which is pushing the anti-abdominal wall to make it a large 20 into 20 centimeter swelling. Do you think there is space for this movement of the kidney?
No, sir.
When you push?
No, sir. We can't elicit in if the tumor is very large in size.
Exactly. So in this situation, because of the large size of the mass, I don't think you should attempt to do a palatability test also. So in this situation,
what is the best example of palatable swelling? Best example. The fecal head is a best sign for palatable. So you are just confusing it with the bimanual palpable palatable. So this type of swelling can be bimanual palpable, but not palatable at all.
Exactly. So in this situation, when the renal mass is so big, we cannot demonstrate palatability. The next question is to comment about whether it is palpable, better palpable bimanual. If you can demonstrate that, then yes, it can be renal mass at large size. but the size has to be small enough to be moved about or touched about. Then only you can demonstrate palatability. So in this situation, probably you cannot demonstrate palatability.
Dikshit, you understood? Dikshit, have you understood?
Yes, sir. Yes, sir.
There should be some space between the anterior-abdominal wall and the mass. Here, as soon as you put a hand, you'll feel. So then it cannot move. You know the meaning of the word ballot? The literal meaning of the ballot? Ballot means toss, toss, head or tail. Tossing. So toss from behind. You don't toss from front to back, but you toss from behind. So need some space. Clear?
I can understand.
Okay, can you show us the next slide, please? Dull note present on percussion. Where?
Over the left.
Over the?
When we percuss over the swelling, there is a dull note present.
So if it was a splenic mass, will there be any characteristic in the percussion?
Any mass arising from the spleen, it must be dull on percussion, sir.
Okay, so I'm asking him. We agree on that. But is there any other additional characteristic you can tell us while percussing a large mass which is coming up to the umbilicus? What is the direction of the enlargement of spleen in splenomegaly?
Spleen enlarges in inward direction and forward direction, sir. Forward and inward direction.
I don't think that I will be happy with that answer.
Say the lump goes toward the right iliac fossa, okay? It enlarges toward the right iliac fossa.
Right iliac fossa, yes, sir.
Then we can understand inward and upward or whatever you are saying here, no?
Yes, sir.
Okay.
Yes, sir.
Now, where did you demonstrate the shifting dullness in this patient? Which side?
Sir,
In this patient?
Sir, bilateral flank, sir.
In this patient, you will do bilateral, or you will do on the right side or the left side?
Sir,
in this
right, sir, shifting dullness over the left side, sir. Right side, sorry, sir. Right side.
Yes, you have, because there's a big lump there on the left side, so you cannot demonstrate that.
Yes,
so it has to be demonstrated on the right side, not on the left side. Okay.
Yes. Yes.
And then when you're doing the PR examination, you say cavity is collapsed. Which cavity is that?
Sir, rectal cavity. Rectal cavity is collapsed.
What do you mean by that? Rectal cavity is collapsed? What does that mean? Because these words we have never heard, you know. These are the new words which have come from you, jo hai. We say normal rectal lumen is there or the anal lumen is there. Okay, when there is a ballooning is there, we say there is a ballooning is there. But we do not say it is a collapsed one, jo hai, na? Okay.
Yes, sir.
Okay. Go to your diagnosis now, yeah. Go to the diagnosis because a lot of things has to be discussed on the diagnosis. Now go to the differential diagnosis. Now you have started with the epidermal cyst of the spleen, which probably we have never heard. Jo hai, na? What is that epidermal cyst? Epidermal cyst we know on the skin, but of the spleen probably we have not heard. Jo hai, na? I do not know for the other examiners, but we never heard about that there can be epidermal cyst or the spleen may be there as a first diagnosis. Now you are keeping it as a first diagnosis. Now, whenever there is a splenic, even if it is cystic, you think it is there, then the cyst of the spleen, like there is a congenital cyst is there, that should come, or a hydrated cyst should come, or it is a hematoma which has lysed, forming a cystic like the cavity which is coming there, but not this differential diagnosis starting with the splenic abscess. So there is no tenderness. You are saying there is temperature is not raised, there is no tenderness, the patient is not having the fever. So why should keep a possible splenic abscess here?
Sir,
So whatever you have jotted or you have just written that, but you have not used your mind for making a diagnosis.
I think with this, practically it comes out that you have just copied from somewhere and just written down that.
Yes, that's right. Yeah.
You have to apply your mind to say which will be the closest one, according to the history and the findings. I won't
This
think about
pseudocyst of the spleen.
pseudocyst
No,
of
in fact, we
pancreas.
are hearing all these new terms, pseudocyst of the spleen. These are the. Did you discuss when you started presenting this patient in this meeting with your consultants, Jay? Krishna?
sir?
Did you discuss it along with your senior residents were there or some faculty was there? Have you discussed that before coming to this forum?
Sorry, sir.
Sir, Kanna sir, good evening, sir. I think
Good evening. Good evening.
he was could not verify the slide, sir. So they
Yeah, I think so.
informed
Yeah,
him.
that's right. Yeah.
So
Right.
maybe we'll give him one more chance, maybe next week also, sir. Maybe they can review
Right.
and
Yeah.
he needs to be a bit more organized, I think, sir.
Right. Yeah. I think so. Yeah.
Probably
I
it is
think
a
the poor
learning
chap is
experience.
fine.
No, he has done okay in the sense that he has volunteered to come and present. But I think there are a lot of things to learn, and probably not for him, but many of the postgraduates also. How to prepare the slide, how to present the cases. They cannot bring in so many oddities into the presentation. So that is what probably is the learning issue today.
We can definitely make out the effect of COVID plus seeing the cases, etc. But the point here is what Dr. Khanna sir is trying to tell, and even me too, and everyone, is that you have to take somebody's help for looking into the slides once, at least who is senior to you, or rather a staff member. Better, I think. Otherwise, what happens is, sir, they like a write for some mass differential diagnosis. They will put 25 differential diagnoses without really applying what they have in mind. So this list and also the inspection, palpation, everywhere there is some problem of presentation, history. Suddenly he said comorbidities, hematemesis, bleeding, like that. The overall presentation, I think, just need a little bit of improvement. Definitely, yes, sir.
Sir, we will give him chance again in the coming weeks, sir. Hadesh, I will request you to take one other case and present in a better way. Is that okay?
No, sir. Yes, sir. Yes.
Okay. Okay, please unshare your PowerPoint. Now we'll request Dr. Komal, please start your PowerPoint and start your presentation. Faculty, please take over. Komal, please unmute yourself, Kana.
Good evening, respected faculties and colleagues. I am Dr. Komal Sharma from IPGMER Kolkata, and I'll be presenting a case of oral cavity CA. My patient was a gentleman, aged 52 years, resident of Malda town, West Bengal, and a tailor by occupation, who presented to the OPD with the chief complaint of a raw area inside the oral cavity on the right side since the past 5 months. He was apparently well 5 months ago. Then he developed the painful raw area on the inside of the mouth. It was initially small in size, around 1 by 1 centimeter, but rapidly progressed to its present size of 2 by 3 centimeters over 5 months as per the patient's gesture. It was associated with pain on touch and on contact with food while eating, but there was no history of bleeding or any other discharge from the site. There is no history of any dental procedures, ill-fitting dentures, trauma. There is no history of any constitutional symptoms, any loss of appetite or weight loss. There is no history suggestive of distant metastasis, no history of neck swellings, no history of any high-risk behavior, no history of radiation exposure to the face, neck, or any other part of the body, and no history of any other ear, nose, or throat symptoms. The patient does not have any past history of any surgery or any documented major illness. There is no personal or contact history of tuberculosis, and the patient does not have any known allergies. The patient consumes a mixed diet, there have been no recent changes in his bowel and bladder habits or sleep or appetite. The patient does not have any chronic illnesses like diabetes or hypertension. He has a history of smoking cigarettes for 22 years, which he quit 6 months ago. The amount of smoking was 11 pack years. He does not have a history of tobacco consumption in any other form. And he has a history of occasional consumption of alcohol around once weekly. There is no family history of any malignancy in first degree relatives and no history of any similar symptoms in any other family member. Coming to the examination.
Dr. Komal.
Yes, sir.
Right.
One thing
Could you
I would like to add, Komal, is that is there any history of dental extraction and dentures?
No, sir. As mentioned, sir, there is no history of dental extraction or any other dental procedures or no dentures, sir.
Okay.
So can you summarize the history, please, Dr. Komal?
Sir, my patient is a 52-year-old gentleman, smoker, with occasional alcohol consumption, who presented with a history of a raw painful area on the inner surface of the mouth over the past 5 months, which was increasing in size.
The mouth is something, Dr. Komal. Can you be more specific? Is this on the cheek?
Yes, sir, on the inner surface of the cheek, sir.
Yeah, so you should be more specific about it. Rather, mouth means the right. Okay.
Yes, sir.
So, why do you take history of distant metastasis? Do these malignancies have distal metastasis?
Sir, the malignancy of oral cavity might spread to the lungs, sir. But other than that, sir, distal mets are unlikely.
So that I mean, this spread to the lung is also not because of metastasis.
Yes, sir.
Right?
Yes, sir.
Okay, so what do you think you're dealing with now? By your history?
Sir, we are dealing with a lesion of the oral cavity mucosa, probably a case of oral cavity carcinoma, sir.
Okay. Did you take any history of difficulty in swallowing, in opening of mouth?
Sir, the patient had slight difficulty in mouth opening, sir, but he had no dysphagia or odynophagia, sir.
So you've not mentioned it. Any irritation, any pain, or excessive salivation, or any pain anywhere?
Sir, pain has been mentioned over the local area, sir.
Earache. I mean, any pain in the ear, any earache?
No, sir. The patient does not have any ear, nose, or throat symptoms, any bleeding, discharge, or pain from.
Right. So all this has to come. Just go back to your slide. These things are missing in your slide. That's why I'm asking you. Any history of any spontaneous fall of tooth or tooth mobility?
No, sir.
Okay. I mean, it's okay. I mean, but it should be more specific, right? It could just no history of right. It should be more specific.
Yes.
Okay. Should we move to the examination first? Okay, you can move to the examination now.
Yes. So the general physical examination, on the examination, vitals were stable. The pulse in the right radial artery was 78 per minute, regular, normal volume and character. The blood pressure measured in the left arm in supine position was 108 by 70 millimeters of mercury. Respiration was 16 breaths per minute, regular, thoracoabdominal type. There was no evidence of pallor, icterus, cyanosis, clubbing, or pedal edema. There was a cervical lymphadenopathy palpable, which has been described in the regional examination later. There are no palpable lymph nodes on any other side, sir. The systemic examination, sir, the cardiovascular, the respiratory, and the neural systems are within normal limits. On regional examination, there was no facial asymmetry. There was no visible neck swelling, neck vein engorgement. Mouth opening was adequate, but the patient had some difficulty. The orodental hygiene was poor. There was halitosis and nicotine staining of the teeth present. On examination of the oral cavity, there was submucous fibrosis along with multiple erythroplakic patches. There was a visible ulcerative growth over the right buccal mucosa, extending present opposite to the molar teeth. The lesion was around 2 by 3 centimeters in size. The margins were irregular and the edges were reverted. The base of the lesion was indurated and the induration extended beyond the margin of the lesion. The retromolar trigone was not involved. The gingivo-buccal sulci were not involved.
Sorry to interrupt. I just want to mention, you have mentioned patient has got submucous fibrosis, but you have mentioned the mouth opening is adequate.
Sir, the patient had some difficulty in fully opening the mouth, sir, but it was adequate for examination, sir, is what I meant.
Okay, what do you mean by adequate? How much should be the mouth opening normally?
Sir, the tonsillar pillar should be visible, sir.
No.
Sorry, sir, I'm not aware of this. Sir.
Right, it's about 3.5 centimeters, or we can insert two fingers.
Okay,
right?
sir.
Inter-incisor distance should be 3.5 centimeters.
Okay, sir.
In Bengal, the whole of the rascula can go inside the mouth and it is adequate.
Yes. Big Bengali Rasgulla. Okay, please go on.
Sir, the retromolar trigone was not involved. The gingivo-buccal sulci were not involved. Tenderness was present over the area of the swelling, but they did not bleed on touch. The parotid and submandibular gland openings were visualized at the normal sites. The examination of the cranial nerves 7, 9, 10, 11, and 12 were normal. There was a single 1 by 2 centimeter hard lymph node present on the right side at level 2. It was non-tender and no matting was present. The lymph node was mobile. There are no other cervical lymph nodes palpable. Common carotid pulsations are palpable on both sides. The scalp, the scalp, the cervical spine, and the ear, nose, throat examinations revealed no abnormalities. Sir, this is the picture of the swelling. There are erythro and leukoplakic patches, and so the ulcer is visible opposite the upper molar teeth, sir. In summary, a 52-year-old male patient, a chronic smoker with occasional alcohol intake, with an ulcerative lesion in the right side of the oral cavity since 5 months. Insidious in onset, rapidly growing, associated with pain, without any constitutional symptoms. On examination, there was submucous fibrosis with leuko and erythroplakia, around 2 by 3 centimeter ulcerative growth on the right buccal mucosa, with irregular margins, everted edges, and induration extending beyond the margin. Retromolar trigone and both gingivo-buccal sulci were free, no symptoms of cranial nerve involvement, and there was a significant cervical lymphadenopathy present in ipsilateral level 2 lymph nodes. The provisional diagnosis is a 52-year-old male chronic smoker with an ulcerative growth of the right buccal mucosa and cervical lymphadenopathy, most likely malignancy of the oral cavity, stage SE-T2, N1, MX.
Okay, Dr. Komal, why do you think the patient was having pain? What was the cause of pain? You said there is painful. Just go back. Here you mentioned pain. Before in your history, you didn't mention pain, but here you are mentioning.
Sir, there was pain on contact with food, sir, while eating, sir.
Okay.
Especially in contact with food and spices, sir.
Okay, so why does he have this kind of pain? What's the reason for pain? Okay, that's because of infection. Because malignancies are usually painless, isn't it?
Yes, sir. Yes, sir.
So why is that pain here?
Sir, since sir, it's an ulcerative growth with epithelial damage, sir, and the contact with food and spices might be a nociceptive stimulus.
Okay. So, okay, so please carry on. Okay.
Sir, this.
Okay, hang on, Kumal. Then, if someone's asking you. Okay, can you tell me the extent of the oral cavity? What constitutes the oral cavity?
So the oral cavity extends from the above. Sir, the upper boundary is the hard palate. The lower boundary is the floor of the mouth, sir. The anterior border is made by the.
No, is it the hard palate or is the soft palate included in the oral cavity?
Sir, the soft palate is included, sir.
Right. So it's the soft palate till the junction of hard and soft palate superior.
Yes, sir.
Yes. Right. And inferiorly?
Inferiorly, sir, the floor of the mouth.
Floor of the mouth. I would say anterior facial pillar and the circumvallate papilla of the tongue. Be more specific. Okay. Okay. Now the patient is also having leukoplakia and erythroplakia.
Yes, sir.
What do you mean by leukoplakia?
Sir, leukoplakia, sir, it is a pre-malignant lesion of the oral cavity. Sir, presenting as white painless patches on the mucosal surfaces of the oral cavity, sir.
And anything more? How will you distinguish this from Candida infection?
Sir, painless, sir.
Candida is painless, not necessarily painful. Candida can be rubbed off. Leukoplakia
Yes,
cannot.
Yes, sir.
Right?
Yes, sir.
So, do you know the types of leukoplakia? Do you know what kind of leukoplakia is more likely to progress to malignancy?
Sir, the types of leukoplakia, sir, homogeneous and non-homogeneous leukoplakia might be there. Sir, homogeneous leukoplakia is.
The term is speckled and nodular.
Yes, sir. Speckled, nodular, or verrucous, sir. Out of these, the proliferative verrucous type has the highest chance of progression to malignancy, sir.
Okay. And what erythroplakia? What is erythroplakia?
Sir, these are reddish patches, which reddish patches which are also pre-malignant lesions of the oral cavity, sir.
So, which is more, which is more likely to convert into malignancy? An erythroplakia?
Sir, between these two, sir, erythroplakia has a higher malignant potential, but leukoplakia is more prevalent in the population. Sir.
Okay, so what is the percentage of a person? Someone comes to you with leukoplakia. What will you tell him? How much is the percentage chance of it turning malignant annually?
Sir,
is it very common?
Is
it very common, or
no,
is it
sir,
rare?
In leukoplakia, the malignant, sir, the risk is very low risk in case of leukoplakia,
right.
Sir.
It's about 1%.
But high risk in case of erythro.
It's about 1%.
Yes.
So, what are the other pre-malignant conditions in the for the oral cavity?
Sir, other pre-malignant conditions include sir, Plummer-Vinson syndrome, sir, submucous fibrosis.
No, we're talking oral cavity, right? Okay.
Sir, submucous fibrosis, sir, then lichen planus may be there. Xeroderma pigmentosum in case of CA tongue, sir. Then, sir, syphilitic glossitis is a pre-malignant condition. Sir, DLE.
No,
DLE,
I mean you can't give me a Dhobi list of all this. These are just finish it off here. Leukoplakia, erythroplakia, lichen planus. That's it.
Yes.
Okay.
Sir.
When you suspect that this pre-malignant condition is turning into malignancy? When will you suspect that? What happens what happens to the erythroplakia, leukoplakia that you suspect that's turning malignant now?
Sir, there might be sir, an increase in size, a rapid increase in size, or induration, the new development of induration or ulceration over the previous lesion.
Right.
In most of the cases, it's a non-healing ulcer.
Yes, sir.
With the conservative treatment, it is not going to heal. Then you can think of malignancy in these cases.
Yes, sir.
Right. So you will find that there is an ulceration, there's color change, there's loss of teeth, there'll be lymph nodes coming up, right?
Yes, sir.
All that. So please, Dr. Raj, please carry on.
How will you proceed further for management of these cases?
Sir, we will proceed, sir, with sir, imaging and tissue diagnosis in these cases, sir. Sir, we will take a wedge biopsy from the margin of the lesion for assessment of the histological type.
Komal, can you show us the picture, please?
Yes, sir.
Show the picture, please.
Yes,
okay. So where do you think will you take the biopsy from? Above, below, anteriorly, posteriorly?
Sir, anteriorly, sir.
Why? Why would you like to do it not anywhere else?
Sir, because the rest of the margins look necrosed and the HPE might be inconclusive, sir.
More important? More important?
Plus, sir, posterior. If we take the biopsy posteriorly, it might it might be a cause for further spread of malignancy, sir. Posteriorly, it might go and involve the.
It becomes less accessible.
Yes, sir. It will become less accessible to research.
Less accessible. Yes, sir. Okay. You want to take a wedge biopsy. What about a punch biopsy? Can you take a punch biopsy?
Sir, okay, I have not read this, but maybe, sir.
Okay, okay, Komal. Can we just take a shaving? Why do you want to take a wedge biopsy? Can we just take a shaving of this?
No, sir, we need to know the depth of invasion which is necessary for staging.
Right.
Just a shaving from the top of the lesion will not give us the precise depth, sir.
Okay. Sir, please, sir.
Then
Dr. Raj.
What sort of imaging will you require for staging of these cases?
Sir, CVCT of the neck, the head and neck. Sir, the preferred investigation is, sir, MRI, which can show involvement of the tongue.
The buccal mucosa is not going to involve the tongue because tongue is a separate entity. The buccal mucosa is a separate entity.
Sir, we will go for a CVCT of the head and neck. And
yeah.
Okay,
sir,
okay, Komal. Komal,
yes,
sorry. What special thing will you do in CT scan? What is the CT called? Will you can get some special maneuver before you get a CT done?
I'm not aware of this, sir.
It's called a puffed cheek.
Okay, sir.
Okay. It's called a puffed cheek. Okay, sir. Okay. And he spoke about depth of invasion. How much depth would worry you?
Sir, if it involves if it is fixed to the buccinator muscle, sir, then the depth of resection will be more.
So in classification, you have buccinator and skin and mucosa and submucosa, is it? To describe the depth?
No, sir. Sir, in classification, it is in millimeters, sir.
Right. So how much millimeter will you? How much millimeter would worry you? More than that?
Sir, more than 5 millimeters, sir.
Right. Why? Because why? Why more than 5 millimeters? Not 3 millimeters of 10 millimeters, 7 millimeters?
Sir, the staging of the disease and changes according to
the disease-free interval is almost 95% if the depth is up to 5 millimeters.
Less than 5, sir. Yes.
Up to 5 millimeters, okay. Sir Rajkumar, Dr. Rajkumar. Okay.
In CT imaging, what are the other parts will you like to see for?
Sir, we will like to see the the neck nodes for lymphadenopathy, sir. We would like to see whether there is any involvement of the the skull base, any bone involvement, sir, and
mandible and maxilla is one of the important parts.
Yes, sir. Mandible, sir, bone invasion, sir. Mandible and maxilla.
If the bone invasion is there, then you have to take note of that.
Yes, sir.
Dr. Komal, sorry, sir. Dr. Komal, what is his dental formula? Have you mentioned that?
Sir, no, sir, I have not mentioned the dental formula of this patient, sir.
Okay. And have you examined the cheeks from outside?
Yes, sir. Sir, externally there was the skin over the cheek was normal and no swelling was visible on inspection.
So how will you
external
know?
inspection, sir.
How will you know that this ulcer base is not fixed to the skin on the cheek?
Sir, bimanual, sir, we will palpate bimanually, sir. Examining the ulcer with one hand while keeping the outer surface of the cheek fixed with the other. We will try to move the lesion perpendicular to the muscle direction, and we will see if there is any movement of the muscle along with the lesion, sir.
So if you move the base of the ulcer, does the skin get distorted or not?
Yes, sir.
That is the way, right?
Yes, sir.
Sir Rajkumar, sir, please. Sir.
Then how you will plan the surgery for these patients once you have diagnosed it? It's came out to be malignancy. What sort of surgery will you like to plan for these cases?
Sir, wide local excision, sir, with neck dissection. Usually, sir, sir, MRND is done. And sir, if there is bony involvement, sir, mandibulectomy might be required, sir, along with a reconstruction technique, usually a PMMC flap or a forehead flap, sir.
The bony reconstruction cannot be done with the PMMC flap?
No, sir. If the bony reconstruction is required, a fibular graft might be required, sir.
What sort of graft are commonly used nowadays? What sort of graft are commonly used nowadays for reconstruction of mandible?
Sir, for mandibular reconstruction, sir, fibular graft, sir.
These are the most of the time people are using the free grafts.
Yes, sir.
Composite graft, including bone, muscle, and skin, with the microvascular anastomosis with the vessel in the vicinity, and then they are putting all these things.
Yes, sir.
So microvascular graft, composite graft is usually used for reconstruction of the bony defects.
Okay, sir.
Komal, what are the principles of reconstruction?
Pardon, sir?
Komal, can you hear me?
Yes, sir, I can hear you now.
What are the principles of reconstruction of the oral cavity in patients with the oral cancer? What are the principles of reconstruction?
Sir, sir, restoration of functionality of the oral cavity, sir.
Yes.
Sir, there should be
restoration of the yes. So you have to read the anatomy as well as the physiology also.
Yes, sir.
Okay, so that is the basic principle that you have to reconstruct not only the anatomical part but also the physiological part also.
Yes, sir.
So you have to carry it out usually in how many layers you reconstruct the oral defects?
Sir, using 3 layers, sir. Sir, the
Yes.
skin, the soft tissue and the bony structure, sir.
So lining, cover, and support.
Yes, sir.
So lining is the mucosal part, cover is the skin,
Yes, sir.
and support is the bony.
Yes.
Okay.
Yes, sir.
So in this patient, how much margin you are going to take?
Sir, ideally a margin of more than 1 centimeter should be taken.
Yes. And if you are you going to do the resection of the excise the skin also or not?
Pardon, sir?
Will the skin will be saved in this patient or it will be excised?
Sir, in this patient, sir, clinically the buccinator muscle was involved, so the full thickness of the cheek has to be excised, sir.
Okay, so skin will also go with that, isn't
Yes,
it?
sir. Yes, sir.
Okay. So now you have
Common
to
for margins, we have to take the help of the frozen section. If margins run positive, then we have to take one more wide margin. So you have to take the help of the frozen section to see the margins that becomes negative. So it is very important while doing reconstruction in a primary setting. So margins should be negative in all the cases.
Yes, sir.
Dr.
okay.
Komal,
So how you are going to construct the mucosal hair or the lining, the cover and the support? How you are going to provide that?
Sir, we
Tell
can.
me, what are the various ways to provide the lining? What are the various ways to provide the lining?
Sir, in this case, we had performed the pectoralis major myocutaneous flap. Sir, where the defect was replaced with the pectoralis major muscle, sir. The lining reconstruction, sir, exactly mucosal reconstruction, I'm not aware, sir.
Lining is
And how
always
did you
given as
provide
fiber.
the cover in this patient?
Sir, the
How did you provide the
flap
cover?
was myocutaneous, sir. Sir, the skin over the pectoralis major muscle was taken, sir.
So the same flap was used for both lining and the cover?
Yes, sir.
It is very
And
difficult
did you
to have.
provide us, did you? Yeah, it's very difficult,
It's
you know,
very
to provide
difficult
both the
to
things
for
by
both the things.
this flap. Many times you have to use a double flaps. So one you will use a delta pectoral, another you will use the pectoral myocutaneous flap there.
Yes.
Or you provide the lining with, like the tongue can provide the lining. You can use the part of the tongue to provide the lining, and you can use some other flap to provide the cover. But the best will be the microvascular one. Okay.
Okay, sir.
With the microvascular, you can do so. You can take the from the radial artery forearm flap. You can take, and you can provide the both the lining as well as the cover, and that will also provide the physiological betterment will be there if you provide the microvascular flap.
Okay, sir.
What are you going to do with the lymph nodes? What type of
Sir,
dissection you are going to do?
Sir, in this case, we performed the type 2 MRND, sir.
What is that?
Sir,
What is type
sir,
2?
sir, in type 2 MRND, sir, there was excision of the lymph node from levels 1 to 5. Sir, internal jugular vein and submandibular gland, but the sternocleidomastoid muscle and spinal accessory nerve were preserved, sir.
So can you tell what is type 1, type 2, and type 3?
Sir, in type 1, sir, only the spinal accessory nerve is preserved. And in type 3, sir, sternocleidomastoid, the IJV, and the spinal accessory nerve, all three are preserved, sir.
Okay. Now,
okay,
can you
Komal,
tell few of the incisions which are made for the neck dissection?
Sorry, sir.
Incision for the neck dissection. Can you tell few incisions which are made for the neck dissection? 2 flap technique, 3 flap technique, 4 flap technique. Do you know something? Kreis incision, Hayes Martin incision.
No, sir.
Okay. Yeah.
okay, Komal, like sir was asking,
Yeah. Please can you?
Why have so many incisions been devised for radical neck dissection? Anything important? Why do you think?
Sir, cosmesis and exposure, sir.
And more important? One would be coverage of the carotids and necrosis
sir.
of the flaps.
Yes.
That's why. Okay. In AJCC 8, depth of invasion was included,
Yes, sir.
right? So,
Yes, sir.
What was the changes which was done in AJCC 8, which is different from AJCC 7?
Sir, firstly, the inclusion of the depth of invasion. Then,
What was the changes made?
Sir, the depth of invasion was included. Sir, the T0 was excluded, sir.
Why was T0 excluded? Why was T0 excluded? Any reason for it?
Sir, I'm not aware of the reason, sir.
Okay, the reason is that when you T0 means there are lymph nodes with no visible lesion, isn't it?
Yes, sir.
So when they did a FNAC when they did a study of the lymph node, it was found that most of them were nasopharyngeal carcinomas.
Okay, sir.
Right? So T0 was removed.
Okay, sir.
If there is no lesion with a lymph node in the neck, then it is usually a nasopharyngeal carcinoma. That's why it was removed. Okay.
Yes, sir. Sir, another change was the special inclusion of HPV positive malignancies, sir, as a P16 positive malignancies, and a separate T staging for these malignancies, sir.
So you think HPV has a better prognosis or poor prognosis?
Sir, HPV has a better prognosis since, sir, antiviral therapies can be given additionally, and prevention, screening and prevention can be done, sir.
Okay. Do you know anything about ENE, extranodal extensions?
Yes, sir. Sir, extranodal extension. Sir, the presence of extranodal extension changes the end staging, sir. N2A, sir, includes.
Okay, that's fine. That's
sir,
fine. Okay, it's okay. That's fine. That's fine. Okay. Also, there was another change which is important, is that any tumors 1.5 centimeters with depth of 4 millimeters was taken as T1 and 6 millimeters taken as T2. When it was in AJCC 6, both were taken as T1. So more than 6 millimeters of depth was taken as T2 now.
Yes, sir.
Okay.
Komal, can you tell what are the various differences between the HPV positive cancers and the HPV negative cancers?
Sir, HPV positive cancers are usually warty lesions clinically.
Where are the HPV positive, or what is the common site for that? For the HPV positive lesions?
Sir, the vermilion border of the lip, sir.
No, they are not on the anterior side. Majority of the HPV positive are on the posterior side, you know?
Okay, sir.
So it may be the oropharyngeal cancers, or it may be the base of the tongue may be there. So
okay,
the posterior side rather than right there.
Okay, sir.
And stage wise, if you compare between the two?
Sir, between the two, sir, there is no criteria for depth of invasion in P16 positive tumors. And sir,
usually the HPV are relatively advanced stage. Relatively advanced stage as compared to the HPV negative, but the prognosis is good as compared to the HPV negative there. Okay. Now, when you're doing the dissection, you know, and if the carotid vessels are getting exposed, do you know how to cover that? Like when we are doing the inguinal broad dissection, we cover it by one muscle. Do you know which is that muscle?
Sartorius, sir.
Sartorius is used. So in the neck, which muscle can be used for that?
Sir, the trapezius could be mobilized and used, sir.
Trapezius is not used. Trapezius is for the posterior boundary of that, isn't it?
Yes, sir.
So it's a strap muscle which is there, just like the sartorius. No, that probably you have removed that sternocleidomastoid. Okay, in majority of the radical neck section. Mainly the levator scapulae muscle which is there on the posterior side.
Okay, sir.
Or levator scapulae muscle is used for the coverage of the. What are the other ways to prevent the carotid blowout?
I don't know, sir.
Okay, one is that is covered by this muscle. Second, you do not completely bare that. So that
Okay, sir.
just like when you are doing environment dissection, you do not bare the femoral vessels. Similarly, here also, they are not completely bare. Third is that you have to prevent the skin flap necrosis over that area. And that is why all those types of incision which are there, like the Hayes-Martin incision which is there, the Prial incision is there, they should not cross at that point. Otherwise, there is a chance of having the. So if the angle formation is there at that point, that can get necrosis. So you prevent the flap necrosis at that point, and definitely you have to prevent the infection. So these are the ways by which you can probably prevent the carotid blowout.
Okay, sir.
Okay, cool.
Now,
I just asked you a question about. Sorry.
You find, yeah, please carry on. Yeah, please carry on. Yeah.
What about why is carotid blowout so common in this kind of after radical neck dissection? Why do you think the skin over it gets eroded?
Sir, there might, sir, due to devascularization of the skin and the constant pulsation of the
one is
carotid
that
against
the
it.
blood supply is poor. More important, the carotid pulsations, they rub against the
Yes, sir, the
overlying
constant
skin.
pulsation, sir. Yes, sir.
The pulsations rub against it, and then that's how it gets eroded.
Yes, sir.
Okay, Dr. Komal, you started off with CT and MRI. There are other investigations which are to be done before. And what are they?
Sir, in addition to CT and MRI, sir, we can do a CT thorax or a chest X-ray for lung involvement.
No. Hang on. Any simpler surgeries before you go, before you scale to CT?
Sir, dental, sir, and ortho, sir, OPG, sir, orthopentomogram, sir.
Okay, why do you want to do an OPG?
Sir, if there is a mandibular resection is in case of sir, if alveolus is involved or if mandible is involved, sir.
Okay. What about an ultrasound? Do you want to get an ultrasound done?
Sir, a USG of the neck might be useful
what
in.
What are you looking for? What are you looking for?
Sir, carotid sheath involvement and sir, lymphadenopathy, sir, which might not be detected on CT.
Okay. And why do you want to get an MRI done? CT is sufficient. What are the indications for getting an MRI done?
Sir, MRI is more indicated when sir in CA tongue etc. for.
Okay. No, even here we can get an MRI done. Even in cheek we get an MRI done. Why do you want to? What are the indications?
Sir, if you want to delineate any muscle invasion, sir, buccinator muscle invasion might be.
Okay, we want to see the spread, right? Local spread and
local spread, sir.
Neurovascular involvement.
Yes, sir.
Right. Okay. Now, okay, you've done the surgery. Any role of radiotherapy here?
Yes, sir. In case of advanced disease, sir, we can go for radiotherapy or followed by surgery, or sir, we can go for adjuvant radiotherapy if in case surgical resection is not achieved.
So,
sir.
Suppose you're planning for a radiotherapy, what investigations will you get done importantly before going for radiotherapy?
Sir, for local assessment, sir.
Yeah, okay, local assessment, whatever assessment. Yes, local assessment, let's say that. Do you have an idea? Okay, you must get a TSH done.
Yes, sir. Systemic investigations, sir, will include a TSH, blood counts.
No, systemic. Why do you want to get a TSH? Look, hang on, Kumar.
Yes, sir.
In all radiotherapies, we don't get a TSH done.
No, sir. Sir, in this case, sir, since it's a head and neck exposure, sir, and there might be development of CA thyroid.
Okay, if the
secondary
patient is
to
going to,
radiation.
it can go, patient can go into hypothyroidism also because of that.
Yes, sir.
So you must know the level of TSH.
Yes, sir.
Okay. Right. What about follow-up? Okay, before that, you've done a radical neck dissection. How do you know your radical neck dissection is adequate? You have an idea, Komo?
No, sir.
There should be how many lymph nodes, at least?
No, sir. I don't know this, sir.
1 dozen. 1 dozen banana should be there.
Okay, sir.
Okay, 12 lymph nodes minimum. Okay, so let's go back to before all this surgery and all. How do you the patients come to you? You suspect it's a CA of the oral cavity. Now, how will you start managing the patient before you take him up for definitive surgery?
Sir, we will sir, improve the oral hygiene of the patient to prevent post-operative infections. We will improve the general condition of the patient, especially in cases where the oral lesion is preventing the patient from eating. We might have to do a gastrostomy or a feeding jejunostomy for improvement of the nutritional status, sir.
Feeding jejunostomy, okay. I mean, that's carrying it a bit too far. More important, right? You're very right. Dental care. If there are any loose tooths, they have to be removed. Sepsis of the oral cavity, nutrition of the patient, right? And then general an X-ray OPG to make sure that there are no dental involvement, bone involvement. So, what is marginal resection and what is segmental resection of the mandible? How?
Sir, sir, mandibular resection can be either a marginal mandibulectomy or
which is preferred?
Sir, a segmental or a partial mandibulectomy.
Which is preferred? Which is preferred? A marginal or a segmental?
Sir, marginal mandibulectomy is preferred, sir.
Why? Why is marginal preferred?
Sir, bony.
Look, if
sir, there is some bony support even after the surgery, sir. We are not removing the entire mandible, so we might not.
So you don't have to use any prosthesis.
Yes, sir.
Because otherwise the mandible is segmental. You remove a segment.
Yes, sir.
Okay. How is absence of teeth or edentulous mandible affecting your management? Any idea?
No, sir.
Okay, so an edentulous mandible, there is erosion of the superior portion of the mandible, and the bone is eroded, so it becomes closer to the
tumor itself,
mandibular fossa.
Okay, sir.
Right, which carries the, so there is faster spread. Right. Okay, another simple question: which tooth involvement, which suppose the patient has incisors, canines, premolars, and molars, involvement of which tooth will affect the prognosis, make the prognosis worse? Do you have an idea?
Sir, the third molar, sir.
No, the canines. Why? Because the canines have the deepest socket.
Okay, sir.
So please. Dr. Rajgopal, sir. So please, sir.
Yeah. Komal.
Yes, sir.
Hello.
Yes, sir.
Your case is, you think it's an early disease or advanced disease?
Sir, it's an early disease, sir.
Yeah. So, will you, in your case, what is your plan?
Sir, a wide local excision.
Okay. My question to you is, will you do prophylactic neck dissection?
Sir, in this case, sir, we have significant cervical lymphadenopathy. Sir, level 2 lymph node 1/2 centimeter hard node is present. So, sir, we will go for a ipsilateral lymph node dissection.
So that doesn't come now. Prophylactic issue will not come, right?
No, sir.
When do you do prophylactic neck dissection?
Sir, prophylactic neck dissection.
In general, for a say oral malignancy in general, when the nodes are not palpable or ultrasound also has not told any nodes, but still, when will you do prophylactic neck dissection?
Sir, if the depth of invasion is sir more than 8 millimeter, there's a more than 40% chance of sir nodal metastasis.
One based on the depth of invasion, depth
Yes,
of
sir.
invasion of the primary, correct?
Yes, sir. Yes, sir.
Right. Yes. Then second, what are the dangerous sites of oral, malignancy with a high risk of neck nodes? They may not be palpable, but they may be having. So when do you do? Yes. What about tongue lesions? What about floor of the mouth? Hello?
Yes, sir. Sir, the floor of the mouth. Sir, floor of the mouth lesions.
So what
Sir, tongue lesions are more likely to spread to level 1 and level 2 lymph nodes, sir.
That's what I'm trying to tell you. Even when the nodes are clinically not palpable, bare minimum what you can do is what? Yes, you already discussed sometimes supraomoid neck dissection. Okay.
Yes, supraomoid neck dissection can be done.
What do you mean by that supraomoid neck dissection?
Sir, in supra.
What are the nodes you clear? It's in this. Hello.
Sir, pardon, sir.
What are the nodes you cleared? That's my question.
Sir, in supraomoid neck dissection. Sir, I'm unable to remember, sir. I had read this, sir. I cannot recollect, sir. Sorry, sir.
What are the nodes will you get above the omoid belly? That's all you get. No 1, 2, 3 there. Correct?
Yes, sir. Yes, sir.
You have to clear that. What are the other structures are there in that above that? You have submandibular salivary gland is there? Yes or no?
Yes, sir. Submandibular gland is there, sir.
You have to clear that. What about digastric belly? So you have digastric bellies. There's soft tissue,
yes,
fat, lymphatics, all that has to be cleared, right?
Okay, sir.
So that's what you mean by, so that's what is the minimum thing you can do. Now, about the mandible reconstruction, so what are the options you have got? Will you remove mandible in your case now? Here.
Sir, in my case, sir, a mandibular resection was not done.
I just want to know, will you remove? Forget about what has been done. My question to you is, you have to have a rationale in the examination, in the university exam. So what are the indications for removal of the mandible? That's my question.
Sir, if the lesion is within 1 centimeter of the mandible or the floor of, sir, if it's on the floor of the mouth or buccal mucosa within 1 centimeter of the mandible.
So it's better to say clinical and radiological evidence of involvement of the mandible. Okay.
Yes, sir. Yes, sir.
Now, clinical evidence is whatever you are talking, other than the approximately close to it. You mentioned about invasive. Anything else? Mandibular thickening. Okay. Thickening.
Yes, sir.
Thickening, tenderness, pathological fractures, and obviously fracture is advanced. So thickening and tenderness will help you clinically, right? Radiologically? Yes.
Sir, if
yes,
sir, if on CT there is sir, in CT if there is any bony involvement, sir, or alveolus of the teeth are seen to be involved in OPG.
Sir mentioned about canine teeth area and all that thing, no?
Yes, sir. Yes, sir. Dental and
in which patients? In which patients you have early propensity of spread into the mandible, edentulous elderly or middle age or so?
Sir, edentulous elderly patients.
Why?
Sir, because the
already 15 minutes to 10.
Sir, the upper
yes.
Sir, the alveolus is bad, sir.
So there is a almost,
give it to them.
hello. So the regression, the itself, the whole mandible. So
would have
this,
told me.
hello. So who is this?
Sir, I cannot hear you, sir.
I know. Narzo 50A, please. Sir.
Only one is required. Second one we can keep in fridge here. No, not here.
Hello.
We can carry
Yes,
it,
sir.
keep it in.
So
Okay, right? Okay. Tomorrow maybe I'll be there. Okay. I meanwhile was.
what's the indication for using MRI in head and neck malignancy? General, I'm asking general question. Will you do MRI?
Sir, if we are suspecting neurovascular involvement, sir.
Neurovascular due to what? To give an example.
Sir, if there is facial asymmetry or any signs of nerve involvement, clinical symptoms.
Why facial asymmetry?
Back by 5:30 or so. Okay. This program starts at about 8:30.
Sir, cranial nerves.
Cranial nerves. MRI in the oral usually used for tongue lesions. Okay, tongue.
Okay, sir.
Retromolar trigones, very advanced lesions. Skull base, very huge lymph nodal
Base of
masses.
skull lesions, sir. Sir, then pterygoid fossa and
infratemporal fossa. All these are very advanced lesions. All right.
yes, sir.
So that is the time you use MRI. Otherwise, the CT scan is enough. Will you do orthopentamogram? That's what I wanted to tell you. Wanted you to invite that question. Clinical
Yes, sir.
radiological evidence. Clinically, you suspect mandible involvement by digital examination, tenderness, then thickening. Then, of course, you said about the depth of invasion. That usually, then radiologically you take a orthopentamogram. But if you take a CT, it is not required, right? So
yes, sir.
Yes. So how do you reconstruct the mandible? Just one or two questions. If you use PMMC, sometimes it's not required. Why do you remove the mandible? First question. Even if it is not involved sometimes.
Sir, if the if the lesion is within 1 centimeter of the mandible, then even without mandibular involvement, we might have to do a marginal mandibulectomy.
So sometimes what happens is that to advanced lesions, etc., to put the PMMC flap itself, it becomes very easy. Otherwise, it's difficult. Understand? So,
yes,
right. So how do you reconstruct otherwise mandible?
Sir, it can be with a fibular graft, a free microvascular graft, or with prosthesis, sir, like a recon plate.
Yes. So what's the main blood supply of this paddle of the this PMMC flap? Any idea about the main blood supply for that is coming from?
Sir,
pectoral branches of the acromion. Yes, acromion.
Sir, axillary arteries branches, sir.
No, that is correct, but pectoral branches of the acromyothoracic artery. You understand, no?
Yes,
so that's
sir.
how the main paddle of the the PMMC flap
yes,
comes,
sir.
right? So
yes,
few other questions. So about the primary, you should be able to do the diagnosis by you have done a biopsy, then metastatic workup. Local infiltration is the most important thing in oral malignancy. Metastasis, generally do not happen, right? It takes very long time for the metastasis to appear. So
yes,
now
sir.
one more question to you is you had done a block dissection, etc. What's the general mode of death in this kind of a oral malignancy? May not be a newer patient, but in general, advanced lesions. How do they die? You should know the every course of the natural course of the disease. For example, carcinoma of the breast, you had done an MRM, all that chemo, everything. But how do they die like that? So oral malignancy. Yes.
Sir.
Yes.
Sir, wasting, malnutrition.
Wasting.
Woman dies of wasting.
Malnutrition, as somewhere I heard the discussion, you can do some feeding, gastrostomy,
yes, sir.
eat for. So there's some method of dying. First is the local recurrence. Very advanced local recurrence here. Sometimes not amicable for any kind of a treatment. Treatment has failed because they come advanced. You have tried radiotherapy, you have tried chemotherapy, you even tried surgery. Anything else. So recurrent aspiration, aspiration,
Yes, sir. Aspiration,
pneumonia, aspirations, and fungating mass and bleeding, bleeding. They can even come with a massive bleeding. So this is one of the questions for you sometimes in the exam. How do they stop the bleeding? Suppose they ask you, it's only just a question of some time, some months for the patient or days. How do you stop? Okay, where do you ligate the external carotid artery? Just to wind up. Hello?
Sir, the facial, sir, the buccal branch.
Buccal branch. Which buccal branch? Where is the?
Sorry, sir. No, sir. Sorry, sir.
The chair, tongue lesion or whatever, very massive ones, very difficult to. So usually above the level of the superior thyroid artery. The reason being.
Sir, superior thyroid.
Don't say that thyroid, we need blood supply. So that is one of the mistakes done. So maybe you prevent the eddying currents. If you put it ligature below superior thyroid artery there, superior thyroid artery is the first branch. So if you put a ligature below, there could be a thrombus extending to the bifurcation. So these are two things like cancerous cachexia. Then of course, yes, nutritional can happen, but more importantly, bleeding, fungation, then all that recurrent aspirations, etc. Sir, please take over.
Right. And also most important is the lymph nodes eroding into the carotids.
Yes.
There's the torrential bleeding. That is
carcinoma of the penis, these are the squamous cell carcinoma metastasis is notorious for this kind of erosions and fungus. Yes, sir, please.
Right. So clinically, how do you know your patient has a good prognosis or poor prognosis? Clinically, what are the things which you look for in CA, carcinoma of the oral cavity, which tells you the prognosis is not very
Clinically,
good?
sir, the size of the growth, the depth of the invasion, HPV positive.
Depth of the invasion is right. What else?
Sir, the lymph nodal spread, sir.
No, lymph node we can manage. No, not that doesn't.
Sir, HPV positive cancers have a better prognosis. So whether they are P16 positive or not.
No, if the patient comes to you with trismus.
Oh, okay.
That is, the retromolar trigon is involved, right?
Yes, sir.
If there is, the tongue is involved in an oral cavity, cells is involving the tongue, right? And there is skin invasion.
Yes, sir.
Invading the skin. These are the three things which tell you that the prognosis is poor. Okay, how will you follow up the patient? Everything's done. Now, how do you follow up the patient and why? What is so important about following up these patients? What is the risk?
So recurrence.
Why? High risk of local regional recurrence. Why?
Sir, there might be like genetic changes in the local mucosa.
What is that called?
Sir, the term. Sir, it's called.
One field.
Sir, field cancerization.
Right. So there is field cancerization.
Yes, sir.
So you've done it. When will you call the patient back, and what will you do and the follow up? Now that you know that there can be field cancerization, okay. How is if there's a field cancerization, how early can a second tumor present?
Sir, 3 years, sir. 3 years, sir.
3 years is a long time. Almost 5 to 6 months. What is synchronous and metachronous tumors?
Sir, synchronous tumors are second primary tumors, sir.
Within 6 months, isn't it?
Yes, sir.
More than 6 months.
Second primary tumors within 6 months, and metachronous tumors are.
So that's what is here. So 3 to 6 months, never 3 years. So when you call the patient, what investigations will you do? You've called the patient. What investigations will you do?
Sir, CT of the head and neck.
Please, just can't step up straight away to CT scan. There are so many things which have been done before CT. CT is not a tool for you to use just like that. Well, I'll ask you what are the indications for CT then? What will you do? You have to examine the patient
Sir,
clinically.
physical examination, sir. Clinical
Clinical
examination
examination of the patient is most, the first thing which you do,
Yes, sir.
right?
Yes, sir. Yes, sir.
Then-
Clinical examination, sir.
Then you will check for his nutritional status, his performance
Yes, sir.
score,
Yes, sir.
isn't it?
Yes,
Right?
sir. Yes, sir.
Then
Then, sir,
look, we've done the things which you have done for diagnosis. You'll
Yes,
do
sir.
the same thing. You'll do an
Yes,
OPG.
sir. OPG, sir.
You'll get a dental
UFG of the
examination
neck.
done.
Yes, sir.
You'll get a chest X-ray done.
Yes, sir.
You get your lab test done and TSH if you've given RT.
Yes, sir. Yes, sir.
Okay, so all this has to be done, right? And what is the percentage chance of him getting a second cancer because of field cancerization?
Sir, because of
How much percentage? If he says, what will you tell him? Okay, you have treated your primary, but you still have a risk of getting another cancer. Now he'll say, what is my percentage? What is my likelihood of getting another cancer? So what will you tell him? Any idea?
no, sir.
About 7 to 10% per year.
Okay, sir.
Sir, any questions, sir? Professor Srinai?
What sort of radiotherapy will you like to have for these patients? And what is the dose?
Oh, sorry, sir. Sir, I can't hear you, sir.
Komal, firstly, can you stop sharing so that we can all have a
Stop sharing your
gallery view?
Yes, sir.
Sir,
Yes,
all
sir.
examiners, please ask questions, sir, so that can you go? Can you just? Yes. Sir,
Yes,
That's good.
I think Dr. Rajkamal sir asked some question. I think correct, no, sir? Sir.
Dr. Rajkamal, sir?
Hello.
Okay, I think we've done with most of it. Sir,
Yes.
Professor Srinai?
No, I think we'll probably we can slowly conclude, I suppose.
Yeah, Komal, any
Yes, sir.
questions? Do you have any queries, any doubts that you want to ask?
Madam Rachana Gupta, madam, you have some questions.
Sir, I had one question, sir. Sir, is it, sir, this is something I did not find during my reading, sir. Sir, is there any indication of contralateral neck dissection, sir?
Sir, Professor Srinai, please, sir.
Contralateral neck dissection, you are talking prophylactic, or if it obviously I understand is prophylactic, correct?
Yes, sir.
You're
Prophylactic,
talking
sir.
about that.
Yes, sir.
I think oral cavity most aggressive I can consider only is malignant melanoma. Other than that, I think if the
If it is in the tongue, if it is involving the tongue, then we do it.
Okay,
Otherwise,
sir.
we don't. Right? That also when it's aggressive.
Aggressive.
Okay, sir.
Dr. Gupta, any questions, ma'am?
Central part of the tongue, then we can go for the contralateral.
Yes, posterior third of the tongue also, of course.
Posterior one third.
Posterior one third in general has got a poor prognosis because it's unkeratinized compared to anterior two thirds, number one. Number two, lots of lymphatics. Number three, there is a lot of crisscrossing of the lymphatics takes place there. So this is what is mentioned for that. Yes.
Ma'am, please, any questions?
What about follow-up?
Ma'am, the follow-up is, sir, ma'am, the common schedule is for so every 2 months for the first year.
No,
Then every 4 months.
it is 3 months. Komal, it's 3 months.
Okay,
Then
sir.
6 months, then 1 year, then 3 years.
Yes, sir.
Okay, I think we're done. Komal, you've done well. Sir, any comments, sir? Professor Shenoy, sir? Professor Dr. Rajkamal, sir? Dr. Karunakar, any comments? Sir, you're muted. So we can't hear you, Dr. Rajkamal. We can't hear you.
Sir Rajkamal, sir, we can't hear you, sir.
She has presented the case nicely.
Yes, yes.
The reply was also quite good. And I think overall, she is quite good. And as far as the presentation is concerned.
Excellent. Okay, we'll call it a day then, sir. Thank you so much. Professor Kanavel is away, so I'm just chipping in for him. Thank you so much, everyone.
Karunakaran sir, want to say anything, sir? No, sir. Okay, sir.
No, sir.
Okay, good night, everyone, and thank you, everyone, sir.
Good night, sir. Thank you.
Good night.